Right now, more than 100 million people around the world have a disease slowly damaging their eyesight, and most of them have no idea it's happening. It doesn't hurt. It doesn't cause redness. By the time you notice, you may have already lost vision you can't get back. This is what the world can start to look like. Dark patches, blurred streaks, holes in your central vision. This is a real simulation created by the U.S. National Eye Institute to show what someone with diabetic retinopathy actually sees. Here's the scale of it. As of the most recent global count, 537 million adults are living with diabetes, and that number is projected to climb towards 783 million within the next 2 decades. Roughly 1 in 4 of them will develop some degree of diabetic retinopathy. That works out to about 103 million people affected right now. A number researchers expect to pass 160 million within 25 years, simply because diabetes itself keeps becoming more common. Here's the fact that should really land. Diabetic retinopathy is the single leading cause of new blindness among working-age adults on the planet. Not older adults, not children, but people in the middle of their careers and raising families. It earns the nickname silent thief, honestly. It usually causes zero pain. It usually causes zero redness. Vision often stays sharp for years while damage quietly accumulates in the background, which is exactly why it does so much harm before anyone catches it. So what's actually happening inside the eye while nothing feels wrong? It starts somewhere you'd never expect to find a problem. Your blood vessels, and specifically the smallest ones in your entire body. Keep that image of the simulated vision in your head as we go, because everything in the next 10 minutes explains exactly how a disease with zero warning signs gets there, and more importantly, how it's stopped. Before we get to what goes wrong, it helps to understand what's supposed to be happening back there in the first place. Because your eye is doing something genuinely remarkable every second you're reading this. The retina is a paper-thin layer of light-sensing tissue lining the back inside wall of your eye. Think of it as biological camera film, except this film is alive, constantly refreshing, and wired directly into your brain. Light enters through your cornea and lens, gets focused onto the retina, and 2 structures do most of the heavy lifting there. The macula, a small central zone packed with detail-sensing cells, and the optic nerve, the cable carrying that information straight to your brain. Here's the part most people never think about. Living tissue needs a blood supply to survive, and the retina is no exception. It's threaded with an extraordinarily fine network of blood vessels. Vessels so exposed that they're often the very first place in your entire body where diabetes-related damage becomes visible. To put the scale of these vessels in perspective, some of the retina's smallest capillaries measure around 5 to 10 micrometers across, roughly 1/10 the width of a human hair. That's the scale diabetes is operating on. One more term worth knowing before we continue: the macula. It's only about 5 millimeters across, roughly the size of a pea, but it's responsible for your sharp central vision, reading, recognizing faces, and driving. Damage here matters disproportionately, so picture it clearly. A thin, living sheet of tissue, fed by microscopic blood vessels, doing the most important visual work of your life. Now let's see what happens when that blood supply starts to break down. Imagine your blood vessels as an enormous, city-wide network of pipes, carrying essential supplies to every tissue in your body. Now imagine what happens when the liquid running through those pipes turns thick, sticky, and corrosive over years. That's what chronically high blood sugar does. Over months and years, that excess sugar chemically damages the thin walls of the retina's smallest vessels, weakening them the way rust slowly eats through metal pipes, until they start to bulge, leak, and eventually clog entirely. Here's an illustration of exactly what that damage looks like once it's underway inside the eye: weakened vessels bulging into tiny pouches, fluid and blood leaking into the retina, and new fragile vessels beginning to sprout where they shouldn't. Walk through the chain reaction in order. High blood sugar weakens the vessel walls, weak walls start to bulge and leak fluid into the retina. Leaking vessels eventually clog and cut off blood flow to patches of tissue, and starved tissue sends out a chemical distress signal that triggers new blood vessel growth. And this isn't a rare outcome. Nearly everyone with type 1 diabetes, and more than 6 in 10 people with type 2 diabetes, will develop some degree of this damage if diabetes goes on long enough. So the eye ends up fighting 2 very different problems at once. Leaky vessels flood the retina with fluid it doesn't want, and starved tissue calls in reinforcements, new blood vessels that turn out to be far more trouble than help. That second part sounds backwards at first. New blood vessels growing in should sound like healing. It isn't. These new vessels are thin, poorly built, and prone to tearing open and bleeding directly into the eye. Growing new vessels here is a warning sign, not a repair job. So remember this shape of the disease. It's not one single event. It's a slow chain reaction, weakened pipes, leaks, blockages, and a desperate, poorly executed attempt at repair. All of this happens inside a part of your body doctors can actually watch directly in real time without a single incision, and that fact alone makes diabetic retinopathy one of medicine's best understood diseases. Here's the difference laid out side by side. On the left, a completely healthy retina, smooth, clean blood vessels, and even reddish-orange color throughout. On the right, an eye with advanced diabetic retinopathy, visibly disrupted with pale patches and abnormal new vessels. Zooming into that affected eye, doctors are trained to spot very specific clues. The pale, cotton-like patches are areas starved of blood flow. The delicate, web-like growths are exactly those fragile new vessels we just talked about, sprouting because the tissue behind them is crying out for oxygen. Beyond this photo, doctors watch for a handful of other classic clues. Tiny red dots where vessel walls have bulged, small blotches of leaked blood, and yellowish deposits left behind when fluid seeps out and evaporates, leaving fat and protein residue. Here's a genuinely fascinating fact. The retina is the only place in the entire human body where a doctor can look directly at living blood vessels without any surgery at all. No scans, no incisions, just a light and a lens. That exam itself is simpler than most people expect. Eye drops widen your pupil over about 20 minutes. A bright light and a lens let the doctor see the full retina clearly, and photographs are usually taken so specific changes can be tracked precisely over future visits. So here's what an actual visit looks like. Check in, drops go in both eyes, you wait for your pupils to widen, the doctor examines and photographs your retina, and you get an answer, often the same day, about exactly where things stand. One dangerous myth needs correcting here. My vision feels fine, so I don't need an eye exam. Remember Chapter 1, this disease is silent by nature. Feeling fine is exactly what makes annual screening necessary, not optional. So the tools to catch this exist, they're simple and they're painless. The disease that hides from you doesn't get to hide from a good camera and a trained eye. Left unchecked, this damage doesn't stay still. It moves through a fairly predictable arc. It starts small and quiet. A handful of bulging vessels, barely visible. Over years, more vessels weaken and leak. Eventually, starved tissue triggers that dangerous new vessel growth we covered, the point where vision loss becomes a real, immediate risk. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. At any point along that path, a separate but related problem can strike the macula specifically, the part responsible for your sharp central vision. Doctors call it macular edema, fluid pooling and swelling that part of the retina directly. The functional difference is stark. Early on, most people read perfectly fine and drive without issue. In the advanced, vision-threatening stage, straight lines can look wavy, central vision can blur or vanish entirely, and everyday tasks like reading a phone screen become genuinely difficult. Put plainly side by side, early-stage disease has no symptoms, is invisible to the patient, and is highly treatable. Advanced disease can cause sudden bleeding, floaters, and permanent vision loss if it isn't caught in time. Same disease, dramatically different stakes. That said, a few symptoms should send you to a doctor immediately. No waiting for your next scheduled exam. A sudden shower of new floaters, flashes of light, or anything that looks like a dark curtain moving across your vision. Those can signal bleeding or a detaching retina, a genuine emergency. For context on the stakes, of everyone with diabetes worldwide, around 6 in 100 will reach that vision-threatening stage. A smaller slice than the 1 in 4 who develop any retinopathy at all, but a slice with genuinely high stakes if it's missed. What makes this genuinely dangerous is that the jump from early to advanced can happen with almost no warning, bridging the two, quiet damage accumulating for years, then a sudden, symptomatic event. That gap is precisely why waiting for symptoms is the wrong strategy. So the real lesson of this progression isn't the specific stages. It's the gap between them. Regular screening exists to catch you somewhere in that gap, long before a symptom ever forces the issue. Let's make this concrete with a real kind of story doctors see constantly. Priya, 52, a schoolteacher with type 2 diabetes for 14 years, came in for a routine checkup after noticing her student's handwriting had started looking slightly blurry from her desk. Here's how her diagnosis actually unfolded. At her checkup, a photograph flagged early changes. A follow-up scan found swelling in her macula. Within a few weeks, she started treatment. And 3 months later, her vision had genuinely stabilized. In her own words afterward, "I almost skipped that appointment because I felt completely fine. I think about that a lot now." Measured on a standard reading chart, Priya's affected eye had drifted to roughly 20 or 40 vision at diagnosis, noticeably blurred for fine print. 3 months after treatment, it had recovered to close to 20 or 25, near her normal baseline. The decision path her doctors followed was straightforward once they had the data. Photo shows damage, confirmed. Central vision affected, yes, via the OCT scan. That combination triggered immediate treatment rather than a simple watch and wait plan. It's worth sitting with the alternative version of this story. Had Priya skipped that appointment for even another year, that same swelling could have progressed to permanent scarring, the kind of damage no treatment can reverse. What her story actually teaches isn't dramatic. It's almost boring, which is the point. Keep your scheduled eye exams. Don't wait for symptoms. Treat mild blurring as real information, not something to brush off. And know that early treatment genuinely works. Priya isn't a dramatic story. She's an ordinary one, and ordinary is exactly what most successful outcomes with this disease actually look like. So how do you actually get ahead of a disease that gives you no symptoms to react to? The answer turns out to combine one very old habit with one genuinely futuristic piece of technology. The old habit first, an annual dilated eye exam. Every single year, whether your vision feels fine or not, for anyone living with diabetes. The futuristic piece is where it gets genuinely exciting. A retinal camera takes a photo of your eye. That photo gets analyzed instantly by an AI system trained specifically to spot diabetic retinopathy. And the system tells you on the spot whether you need to see a specialist, no ophthalmologist required in the room at all. This isn't hypothetical. In 2018, a system originally called IDX-DR, now sold as Luminetic Score, became the very first autonomous AI diagnostic system ever authorized by U.S. regulators in any field of medicine for any disease. In its pivotal trial, it correctly flagged referable disease with roughly 87% sensitivity and 90% specificity. Sit with that for a second. The very first disease in the history of medicine that regulators trusted an AI to diagnose completely on its own wasn't cancer or a heart condition, it was this one. That shift matters practically, not just symbolically. In the old model, screening required a specialist eye clinic, often a long wait, and travel most people couldn't easily manage. The new model puts a camera and an AI reader directly inside a regular diabetes checkup. No specialist visit required just to get screened. And prevention itself has hard evidence behind it. In one of the largest trials ever run on this, tightly controlling blood sugar cut the risk of ever developing retinopathy by roughly 3/4, and slowed existing damage by more than half. So the actual prevention checklist is short. Keep blood sugar in your target range, keep blood pressure controlled, don't smoke, and get that dilated eye exam every single year without fail. For habits doing an enormous amount of protective work. Between a decades-old habit and a genuinely cutting-edge piece of technology, this is now one of the most preventable causes of blindness that exists. The tools just have to actually get used. Even after damage has progressed, there's real, effective treatment. This photo shows the retina after laser therapy. You can see the small round scars left behind, evidence of a treatment that's been saving sight for decades. That laser treatment, called photocoagulation, works by placing hundreds of tiny, precise burns across the retina's outer edges. It sounds harsh, but it sacrifices a small amount of peripheral tissue specifically to reduce the tissue's oxygen demand, which shuts down the signal driving those dangerous new vessels to grow. Alongside laser, a newer option has become standard. Injections directly into the eye of medication that blocks the exact chemical signal starved tissue sends out to trigger new vessel growth, effectively starving the problem at its biochemical root. The evidence behind these treatments is decades deep. Laser treatment, tested in the landmark trials of the 1970s and 80s, cut the risk of severe vision loss from advanced disease by more than half. Modern injection therapy has matched or improved on that record since. Neither treatment is universally better. They suit different situations. Laser is a one-time procedure with lasting effect but can slightly narrow peripheral vision. Injections preserve more of the surrounding retina but typically require repeat visits every few months to stay effective. So here's what actually matters starting today, whether or not you have diabetes yourself. Know your own or a loved one's diabetes status, protect blood sugar and blood pressure, and treat "I feel fine" as a reason to still get checked, not a reason to skip it. A disease that took away sight silently, for decades, undetected, can now be caught by a camera and stopped by a needle or a laser. That's not a small story. That's one of modern medicine's genuinely underrated success stories. The eyes you have right now are worth one appointment a year. That's the entire, unglamorous, extraordinarily effective secret behind preventing this disease. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.